Part 2. Number 31. Tumor markers are especially valuable when used to letter A. Rule out cancer. B. Screen the general population for cancer. C. Monitor response to cancer therapy. Or letter D. Confirm other assays. So remember, tumor markers, these are substances produced by either the tumor or as a response by a healthy tissue to a tumor. So, while sometimes used for a purpose, for other purposes, tumor markers are generally useful and or valuable for evaluating the progression of a disease or a condition. Okay, and also for monitoring. So it is used very important in evaluating the progression and monitoring of response to cancer treatment. Okay, so tumor markers represent a diverse group of molecules, okay, which include serum proteins, hormones, receptors, enzymes, oncofetal antigens, and metabolites. So for number 31, okay, we cannot use tumor markers to rule out cancer, screen the general population for cancer, or confirm other assay. Hindi po. So we use tumor markers, okay, in evaluating the progression of the disease or monitoring the response to cancer therapy. So the answer for number 31 is letter C. Letter C. Monitor the response to cancer therapy. Number 32. Hyperacute rejection of transplanted organ is caused by letter A. Preformed humoral antibodies in a patient. B. Patient sensitization to donor antigens. Development, for letter C, development of allogenic reaction for donor antigens. Or letter D, the disturbance of host graft tolerance. So for the number 32, the answer is letter A. So let's discuss each. Okay? So let us describe first or define first what is a rejection. So rejection, this is a non-self-discriminating power of the immune system. Okay, it is undesirable in therapeutic setting such as in transplantation, cells, okay, a transplantation of cells, tissues, organs from one person to another. So rejection or graft rejection, okay, depends on the expression of the MHC antigens on the surface. That's why red blood cell transfusion is an exception to graft rejection. Why? Because red blood cells, okay, do not express MHC antigens on their surfaces. Okay? So this is the reason why it is easier to transfuse blood as compared to organ donation. So what are the categories of rejections? Particularly allograft, okay, rejection. So when you say allograft, this is a transplantation from one individual to another individual of the same species. Okay? So the categories of allograft rejection includes hyperacute, okay, hyperacute, and then we have acute rejection. We have also chronic rejection. Okay, chronic rejection. Okay, so the definition of your hyperacute rejection, this occurs within few minutes. Kaya siya sinabing hyperacute, mabilis siya. Okay, it appears within minutes to few hours, actually within 24 hours of transplantation. Okay, so a result of destruction of the transplant by so-called preformed, or pre-existing antibodies to incompatible MHC antigens and to carbohydrates expressed on transplanted tissues. Okay, so the mechanism of hyperacute rejection is the cytotoxic antibodies activate the complement system. So we have your cytotoxic antibodies activating the complement system. Okay? So we have your acute rejection. Okay, acute rejection. Acute rejection occurs within weeks rather than in minutes or few hours, as with the acute rejection. Acute rejection within minutes. Okay? Ito within minutes or hours. Ito si acute within weeks. Again, hyperacute within minutes and hours. Ang acute within weeks. Okay? So, acute rejection is seen in among recipients, okay, who has not previously been sensitized to transplant. So we have types. We have your humoral acute rejection and acute cellular rejection. The humoral acute rejection occurs within first 3 months following transplantation. Okay, 3 months following transplantation. That is a humoral acute rejection. Cellular rejection, okay, usually occurs 1 to 6 weeks to several years following transplantation when doses of immunosuppressive drugs are lowered. Okay, we have your chronic rejection. Chronic rejection, okay, is caused by antibody and cell-mediated immunity, okay, occurring in allograft transplantation. So this type of rejection occurs within months, okay, months or years, okay, or years after the transplanted tissue has assumed its normal function. Okay? The transplanted organ or tissue has assumed normal function. It's a chronic rejection. Okay? Antibody and cell-mediated immunity. Okay, that is the mechanism for chronic rejection. So, to discuss, number 32, okay, since our answer is letter A, preformed humoral antibodies in patient, which describes hyperacute rejection. So, the presence of preformed humoral antibodies in patient, okay, reacting with donor tissue, cellular antigen is entire cause of hyperacute, okay, rejection. Okay? The preformed antibodies are usually anti-A and anti-B related to antibodies to the ABO system or antibodies to class 1 MHC antigens. Okay? So, this is usually observed in hypersensitivity reaction type 2. Okay? This is observed in the hypersensitivity reaction type 2. Okay, letter B, patient sensitization to donor antigen. Okay, so previous patient sensitization to donor antigen is a T-cell mediated caused by accelerated rejection or graft rejection. Okay, this is seen among kidney grafts. Okay, it is comparable to the second set rejection phenomenon observed in animal models of graft rejection. Letter C, development of allogenic reaction to donor antigen. This is observed in an acute rejection. Okay, this is observed in an acute rejection. This rejection can result after the first exposure to antigen. Okay, after first exposure to antigens. Although, the early process of rejection, equivalent to a first set allograft rejection in experimental animals is mediated by T cell. Okay, later rejection may involve antibodies and complement, possibly antibody cell-mediated cytotoxicity. So, naalala nyo kanina, Okay, we have two types, humoral and then the acute rejection. Okay, the humoral and the cellular acute rejection. Okay, we have letter D, disturbance of host graft tolerance. Okay, the disturbance of host graft tolerance is seen in chronic graft rejection. This is a cell-mediated process, okay, that develops later than 3 months after transplantation. Okay, chronic rejection occurs in most graft recipients. Okay, the process produces a slow but continual loss of organ function. So that is letter D. So for number 32, hyperacute rejection, this is letter A. Preformed humoral antibodies in patients are present. Okay, na is number 32. Number 33. Number 33, corneal tissue transplantation has an extremely high success rate, okay, for a variety of reasons, including all of the following with the exception of letter A, avascularity, B, reasonable low concentration of class 1 antigens, letter C, an essential absence of class 2 antigens, or letter D, eccentrically placed grafts. Which of this daw ay exception, okay, in the success of corneal tissue? Corneal tissue or cornea is considered as the least immunogenic among tissues being donated or grafted from one person to another. Why? Because of its characteristic, it is technically avascular. Okay? It has low concentration of class 1 antigen, and the essential absence of class 2 antigens contributes to a high success rate, okay, in times that corneal tissues is being transplanted. Exception po yung D. Why? Bakit eccentrically placed grafts, okay, is an exemption? Eccentrically placed grafts of the cornea are subject to high rate of immunologic failure because of vascularity, okay, that will allow contact with lymphocyte. Okay, that can facilitate rejection. So to prevent rejection, corneal transplant are made as small as possible, and the transplant is placed centrally, okay, to avoid contact with high vascularized limbic region. Okay, so the cornea is avascular. Okay, subsequently, no HLA matching is performed for corneal tissue transplant. Class 1 transplantation antigens are present in the cornea in very, very low concentration. Class 2 transplantation antigens are essentially absent in cornea. Okay, so letter D is exception. Number 34, the tumor marker associated with ovarian cancer. This is letter B, CA125. CA125. So CA125, okay, is relatively sensitive in low stage ovarian cancer. This is a classic tumor marker, okay, that is elevated in cancer and benign disease of various organs other than ovarian cancer, such as pelvic inflammatory disease, endometriosis, okay, but also it is most useful in the diagnosis and monitoring of ovarian and endometrial carcinomas. We have your CA153, CA153 slash CA2729. These two tumor markers are associated with breast cancer. Okay, associated with breast cancer. Okay, so CA15-3, this is a marker used to monitor patient response to treatment and recurrence of cancer after mastectomy. Okay, CA2729, this is called the breast carcinoma associated antigen. Again, this is your breast carcinoma associated antigen. Okay, so this is a not recommended breast cancer screening marker. Okay, this is not recommended as a breast cancer screening marker, but the marker may be very helpful in the conjunction with other clinical methods that will that will predict, that will predict the recurrence of breast cancer. Okay, that is your CA 27.29. We have your PSA. This is your prostate specific antigen. Okay, your prostate specific antigen. This is a prostate tissue specific marker, but not a prostate cancer specific marker. Again, your PSA is a prostate prostate tissue specific marker, but not prostate cancer specific marker. Okay, so it is a prostate tissue specific marker, but not a prostate cancer specific marker. So blood levels of PSA are increased when normal glandular structure is disrupted by benign or malignant tumor inflammation. So we can experience false positive elevation, okay, which have been generated in prostate infection, irritation, benign prostatic hypertrophy, and general ejaculation. Okay, the value of monitoring PSA over time is that an acceleration in the concentration of PSA may suggest an increasing tumor volume of prostatic cancer. Okay? So CEA or your carcinoembryonic antigen or CEA, this is a tumor marker that is useful in differentiating between a benign and malignant pleural and ascite effusion. Okay, your CEA is found predominantly on normal fetal endocrine tissue in the second trimester gestation. So CEA is clinically useful, useful in monitoring patients after surgery. Okay, especially the surgery involved colon resection. Okay, who had an initially high CEA blood level. Okay, because CEA is actually a tumor marker which is very helpful in monitoring colorectal cancer. Okay, that is CEA. Okay, please refer to the list. Okay, yung series 1 po ng ating Immunosero, meron po dong table, and in our handouts, meron din po tayong summary ng tumor markers. Very helpful and very important po iyon. Okay? Sige po. Number 35, we have contact dermatitis is mediated by letter A, B cells, B, mast cells, C, PMNs, we have letter D, T cells. So, remember, contact dermatitis, it is an example of a cell-mediated hypersensitivity reaction. Okay? Remember, your your cell-mediated hypersensitivity reaction is a type 4 hypersensitivity reaction involving macrophages, involving macrophages and T lymphocytes. Okay? So, type 4 hypersensitivity reaction. Okay? So, with this, when an antigen comes in contact with the skin, okay, nagkaroon kayo ng contact, okay, when yung antigen na yon, okay, sa skin, okay, so the antigen is processed by the cell in the epidermis and comes in contact with the T lymphocyte. Now, what will happen to the T lymphocyte? T lymphocyte will recognize the antigen as foreign and it will circulate through the bloodstream back to the epidermis. Okay, it will go back, okay, to the epidermis after it went to the circulation. So after that, okay, they release cytokines, okay, producing an inflammatory response, okay, causing a characteristic rashes in the skin, okay, which we call, okay, contact dermatitis. So number 35, we have T cells. Number 36, sorry, wait. So B cells, okay, very important ha. Remember, these are B lymphocytes. This is needed in the antibody production, particularly the plasma cells. Okay, they are not involved in contact dermatitis. We have your mast cells. Mast cells is our key component of type 1 hypersensitivity reaction, not cell-mediated hypersensitivity reaction. Letter C, PMNs. PMNs are recruited to the site where the immune complexes have formed in type 3 hypersensitivity reaction. Okay, number 36. All of the following conditions are associated with polyclonal increase in gamma globulin except letter A, liver disease, B, chronic inflammation, C, immune reaction, or letter D, immunodeficiency. Okay? Pag sinabi dito, increase in gamma globulin. Okay, increase in gamma globulin. This is not a characteristic of the immunodeficiency. Immunodeficiency would of course generally be associated with decrease in serum immunoglobulin levels and an associated decrease in gamma band. Okay, in gamma band, and this is observed in immunodeficiency, okay, condition. Polyclonal increases, okay, are associated with infection, okay, inflammation, what else? Liver disease, rheumatoid disease, and lymphoproliferative disorders. So immunodeficiency, it will not be associated with a polyclonal increase in gamma globulins. Okay, generally, okay, it will present a decrease, okay, or low levels of serum immunoglobulins. Okay? So number 36, exception po ang letter D, immunodeficiency. 37. Severe combined immunodeficiency, or we term as your SCID, is characterized by all of the following immunodeficiencies except A, T-cell reduction or dysfunction, B, B-cell reduction or dysfunction, letter C, natural killer cell reduction, or letter D, a deficiency of stem cells. Okay? So let's define first what is SCID. So in a severe combined immunodeficiency or SCID, it is a collection of congenital disorder that is characterized by deficiency of T and B cells and or natural killer or NK cells. These deficiencies are the severe deficiency of those cells are actually caused by a defect of hematopoietic stem cells rather than deficiency of stem cells. So letter D is exception for number 37. We have two modes of genetic inheritance. This can be X-linked or autosomal recessive. Although most commonly in SCID, it is X-linked related. Okay, wala naman pong important differences in the signs and symptoms existing between the two major genetic types of SCID. Okay? So what we can observe in SCID, number 1, we can observe T-cell reduction or dysfunction. So in SCID, it is caused by the numerous molecular defects that lead to severe compromise in T-cell reduction or dysfunction. B-cell reduction and also dysfunction and occasionally reduction in the number of your NK cells. So in SCID, it is important to remember that there is blocking of T lymphocyte differentiation, okay? And this can be associated with abnormal development of other types of lymphocytes, which are your B cell and NK cells. Okay? So natural killer cells are also reduced, okay, in this case, okay? So they have genetic mutations. Meron tayong tinatawag pagka sa NK cells, we have the 3 gene involvement. We have the IL2RG gene, we have the JAK3 gene, and the ADA genes, which cause, okay, in SCID reduction on NK cell K population. So this express decreased number of NK cells, okay, and decrease or absence, okay, in the circulating T cells. Okay, in the circulating T cells. Okay, so for number 37, the answer, exception po ang deficiency of stem cell. It should be a defect on the hematopoietic stem cells. Okay? Number 38. The type of hypersensitivity reaction associated with macrophages, macrophage activation, cytokine-mediated inflammation is, okay, kanina sinabi natin, macrophage activation, cytokine-mediated inflammation. Okay, this is described in type 4 hypersensitivity reaction. Okay, type 4 hypersensitivity reaction, the cell-mediated or T-cell dependent, okay, hypersensitivity reaction. Okay, so type 4, again, type 4 cell-mediated hypersensitivity reaction, this is associated with macrophage, okay, macrophage activation. Type 4 is characterized by direct target cell lysis and cytokine-mediated inflammation. So there are 3 defining characteristics of type 4 hypersensitivity reaction. We have your type 4 delayed type of hypersensitivity reaction, okay, involving antigen-sensitized T cells, okay, or particles that remain phagocytized in macrophage and are encountered by previously activated T cells or for a second or subsequent time. Okay? So delayed hypersensitivity reaction, okay, is a major defense mechanism against various intracellular pathogens, which includes mycobacteria, fungi, and certain parasites. Okay, another characteristic of type 4, second, okay, rejection of foreign tissue grafts. Okay, the elimination of tumor cells bearing neoantigens. For number 3, okay, third involvement, we have the formation of chronic granulomas. That is in type 4 or cell-mediated hypersensitivity reaction. So number 38, it is type 4. Okay, type 1, type 1 hypersensitivity reaction, this is termed as your anaphylactic or immediate hypersensitivity reaction. Your type 1 immediate hypersensitivity reaction, this is a mast cell-derived mediators. Okay, so mast cell-derived mediator, cytokine-mediated inflammation involving eosinophils, lymphocytes, and neutrophils. Type 1 reaction can range from life-threatening anaphylactic reactions to milder manifestation associated with food allergies. So type 1 is also termed as anaphylactic or immediate hypersensitivity reaction. Type 2, hypersensitivity reaction, this is cytotoxic, okay, antibody-mediated, antibody-dependent, complement-mediated hypersensitivity reaction. So this is associated with complement and Fc receptor mediated recruitment and activation of leukocytes, okay, leukocytes, particularly see neutrophils and macrophages. Okay, we have your type 3 hypersensitivity reaction. Okay, it involves immune complex mediated hypersensitivity reaction. Okay, this is associated with complement and Fc receptor mediated recruitment and the activation of leukocyte and tissue damage, which is secondary to impaired blood flow. So remember that type 3 reactions, these are caused by IgG or IgM and possibly other antibody types. Okay? So to summarize, I have prepared a table for the 4 hypersensitivity reaction for your perusal. Okay? So just check this. Number 39. Which immune elements are involved in a positive TB skin test? Letter A, IgE. B, T cell and macrophage. C, NK cells and IgG antibodies. We have letter D, B cells and IgM antibodies. So, a positive tuberculosis skin test is an example of type 4 cell-mediated delayed hypersensitivity reaction. Okay, so this type of hypersensitivity reaction, okay, involves T cells and macrophages. So, number 39, the answer is letter B. So, a positive TB skin test, okay, it is cell-mediated immunity, okay, moderated by the link between the T lymphocyte and the phagocytic cell. So, this reaction involves antigen sensitization by T lymphocytes, antigen-sensitized T lymphocytes, or particle that remain phagocytized in a macrophage and are encountered by previously activated T lymphocytes for second or subsequent time. So, T lymphocytes respond directly by the release of lymphokines to exhibit a contact dermatitis reaction. This involves the redness, swelling of the skin around the point of contact. Okay, that is the characteristic of a positive TB skin test. So, IgE. What is IgE? IgE, remember, this is associated with type 1 hypersensitivity reaction. Okay, that hypersensitivity reaction, it can range from the life-threatening anaphylactic reaction, okay, to milder manifestation associated with certain food allergies. Okay, so immediate hypersensitivity reaction, okay, this is caused by molecules released by the mast cells when an allergen, okay, interacts with the membrane-bound IgE. Okay, to the membrane-bound IgE. We have the IgE. For the type 2 hypersensitivity reaction, these are initiated by the interaction between the antibody and the antigen. Okay, between an antibody and an antigen. So, antibody cells are lysed, okay, by effector cells such as your NK cells and macrophages. Okay, so NK lymphocytes or NK cells, they lack the conventional antigen receptor for T or B lymphocytes. So, NK cells synthesize a number of cytokines involved in the modulation of immune response. So, NK cells now will destroy target cells through an extracellular non-phagocyte mechanism referred to your cytotoxic reaction. So, that is a type 2 hypersensitivity reaction. So, number 39, again, the answer is letter B. Okay, letter B. Number 40. Which of the following autoantibodies are found in patients with Hashimoto's thyroiditis? Okay, what would be the antibodies, okay, that is involved in Hashimoto thyroiditis? Remember, Hashimoto thyroiditis, let's discuss Hashimoto disease. Hashimoto disease or Hashimoto thyroiditis, also known as the chronic autoimmune thyroiditis. These are often seen among middle-aged women. This patient develop combination of goiter or enlargement of the thyroid. Okay, their presentation, they have also hypothyroidism and presence of thyroid autoantibodies. The thyroid autoantibodies are directed to the antithyroglobulins, antithyroid peroxidase, and second colloid antigen or CA2. So, in this case, we have antithyroid peroxidase in our choices. So, this is an autoantibody which is found in among patients with Hashimoto thyroiditis. So, these antibodies are associated, okay, the antithyroid peroxidases are associated with Hashimoto thyroiditis, Okay, also in Graves' disease, which is the counterpart of the Hashimoto thyroiditis. In this case, si Hashimoto, okay, presents hypothyroidism. In the Graves' disease, they present hyperthyroidism. So your TPO, they are found in about 95% of patients with Hashimoto's and are best indicator of the disease. Okay, 95% of patient positive in 95% of patient with the Hashimoto thyroiditis. Okay? So what is TRAbs? What are TRAbs? So thyroid stimulating hormone receptor antibodies or TRAbs. These are associated naman kay Graves' disease. Okay, kay Graves' disease. Islet K cell antibodies. This is associated with type 1 diabetes mellitus. Anti-transglutaminase or TTG. These are associated antibodies in celiac disease. Okay, in celiac disease. Okay po. Number 41. All of the following are indicators of sepsis except letter A, erythrocytosis, B, increased heart rate, C, leukocytosis, D, increased body temperature. So the answer here is actually letter A, erythrocytosis. Okay? Why? In sepsis, okay, exception po ang erythrocytosis in sepsis. So, sepsis is a result in an immune response by the body. So, the response includes increasing the body temperature, okay, increasing the body temperature and leukocytes in order to fight off the infection. And also, what we observe in sepsis is an increased heart rate, okay, in order to get more blood and oxygen to the tissue. Okay, in this case, erythrocytosis is not part of the immune response, okay, among septic condition. So, A is exception. Number 42. Thymic hypoplasia is an example of A, congenital T cell disorder, B, congenital B cell disorder, or letter C, acquired T cell disorder, or D, acquired B cell disorder. So, very important, no, na alam natin ang examples ng thymic hypoplasia. Okay, this is also known as your DiGeorge syndrome. Okay, your DiGeorge syndrome. Okay, so your DiGeorge syndrome, okay, is a disorder resulting from a mutation in chromosome 22. Okay, in chromosome 22. This is a T cell defect. Okay, T cell defect. Okay, it is congenital anomaly producing faulty embryogenesis of the endodermal derivation of the third and fourth pharyngeal pouches. Okay, resulting in aplasia of the parathyroid and thymus gland. Okay, this will result to the aplasia of the parathyroid and thymus gland. Okay, so this is seen in thymic hypoplasia. So this is a congenital T cell disorder. So we have a congenital B cell disorder. This is exemplified in Bruton's agammaglobulinemia. Okay, in Bruton's agama globulinemia. Okay, in Bruton's agammaglobulinemia is a classic example of X-linked congenital B cell disorder. This is a variant in the gene coding for the enzyme Bruton tyrosine kinase. Okay, in the Bruton tyrosine kinase. Okay, so this enzyme, okay, will lead to the arrest of your B cell development at the pre-B cell stage of cellular development. Okay, so it will lead to the arrest, okay, or halt in the B cell development at the pre-B cell stage of cellular development. So that is a congenital B cell disorder. We have your acquired T cell disorder. Acquired T cell disorder, most well-known acquired T cell disorder, which is your acquired immunodeficiency syndrome or AIDS. So the human immunodeficiency virus, okay, has marked preference or target, okay, for CD4 positive subset of T lymphocyte, leading to, okay, disorders in T cells. Okay, this is an acquired T cell disorder. Okay, for an acquired B cell disorder, multiple condition can create an acquired B cell disorder. Like for example, we have the autoimmune disorders, multiple myeloma, those are the common examples. So other acquired B cell deficiency can be related to conditions such as aging and the effect of various medications. Okay, so number 42, letter A, congenital T cell disorder. Number 43, we have your Bruton's agammaglobulinemia. Okay, it is, kanina as discussed, okay, this is an example of a congenital B cell disorder. Okay, congenital B cell disorder, X-linked congenital B cell disorder. So, number 43, the answer po is letter B, congenital B cell disorder. 44, immunoglobulin M or IgM, it is the characteristically overproduced gene product found in which of the following condition? A, multiple myeloma, B, plasma cell myeloma, or letter C, heavy chain disease, D, Waldenstrom, okay, Waldenstrom disease. Okay, Waldenstrom disease. Paki-correct lang po, Waldenstrom's disease. Okay? So, for number 44, the answer is actually letter D, Waldenstrom's disease. Waldenstrom's disease, or also known as your Waldenstrom's primary macroglobulinemia, this is considered to be a lymphoplasmacytic lymphoma defined by the WHO classification system. So, this is a malignant lymphocyte plasma cell proliferative disorder, okay, producing immunoglobulin M, okay, your IgM. Okay, so IgM is characteristically overproduced gene product in Waldenstrom, okay, macroglobulinemia. Okay, so ano naman meron kay multiple myeloma? Okay, multiple myeloma have 4 subtypes, okay, 4 subtypes. So we have your 4 subtypes of IgG, heavy chains. These are known to exist among patients with IgG myeloma. IgG1, IgG2, IgG3, and IgG4. So it is an IgG myeloma. Okay, IgG myeloma. Okay, so we have the plasma cell myeloma. Plasma cell myeloma, this is referred to the multiple myeloma. Okay, multiple myeloma. So, IgG, it is involved with the production of IgG, okay, immunoglobulins. Heavy chain disease. This is characterized by the presence of monoclonal proteins composed of the heavy chain portion of immunoglobulin molecule. So, we have the alpha heavy chain disease, okay, as the most common of the heavy chain, okay, gammopathies. Okay, example is the alpha heavy chain disease. Okay, example of a heavy chain disease is the alpha heavy chain disease. Okay, most common type of heavy chain gammopathies. Okay, so presence of monoclonal proteins. monoclonal proteins composed of heavy chain portion of the immunoglobulin. Okay. So, number 44, the answer is letter D, Waldenstrom disease. Okay, Waldenstrom disease. Number 45, the most frequent encountered immunoglobulin demonstrated in patients with multiple myeloma. So, the answer here is letter B. Okay, IgG. Okay, IgG. Okay, so about in patients suffering with multiple myeloma, okay, they most commonly encountered immunoglobulin is IgG. Although pwede din naman po ma-detect yung ibang immunoglobulins, okay, but immunoglobulin G significantly okay, shows okay, predominance or increase okay, in production. Pwede rin pong IgM, but only 12% of patients with multiple myeloma. IgA okay, occurs in 22% in patients of multiple myeloma. IgE is rare okay, in patients with multiple myeloma. Kapag ka IgG, they are present in 52% of patients okay, in patients with multiple myeloma. Okay, so again, si IgM, ilang percent ng patient? Only 12%. Okay, so IgA, okay, okay, so this is present in 22% of patients with multiple myeloma. IgE, okay, rarely detected. Okay. Number 46. Number 46, a representative congenital neutrophil functional disorder is an example of which of the following? A. Shijak-Higashi syndrome. B. Gaucher's disease. C. Niemann-Pick disease. Or letter D. Systemic inflammatory response syndrome or SIRS. SIRS. So let's discuss each conditions. Okay, so I have prepared a table okay, that differentiates the disorders of the neutrophils from the monocyte macrophage disorders. So we have Shijak-Higashi syndrome. Shijak-Higashi syndrome is this is a condition representing a qualitative disorder of neutrophil. Okay, so this disorder is expressed as an abnormal granulation of neutrophils presenting giant granules. Okay, the neutrophils present or contains giant granules. Neutrophils with giant granules display impaired chemotaxis and delayed killing of ingested bacteria. So we have another disorder involving neutrophil. We have your CGD, your chronic granulomatous disease. This is a condition or disorder okay, involving oxidative metabolism. Okay, so a defective oxidative metabolism is involved in CGD. This affects the cascade of events okay, required for hydrogen peroxide production by phagocytes. Okay, that is your CGD. Complement receptor 3 deficiency on CR3, okay, deficiency on CR3. This is needed for leukocyte adhesion. Okay, leukocyte adhesion. So decrease in cell aggregation and adhesion by neutrophils by the endothelial tissue. This is presented in CR3 deficiency. Okay, there is a decreased cell aggregation and adhesion by neutrophils. Okay, we have MPO deficiency. MPO or myoperoxidase, okay, is an iron-containing heme protein responsible for the peroxidase activity. Okay, given the characteristic of the azurophilic granules. So, patients, phagocytes, or the phagocytes in the MPO deficient patients, they present mild to moderate defect in bacterial and fungal killing. So these patients, okay, are likely to have, okay, both bacterial and fungal, okay, infection. They are at risk for bacterial and fungal infection. We have another disorder, the specific granule deficiency. Okay, this is the failure to synthesize specific granules by neutrophils. So the neutrophils have the inability to kill and cause inflammation. We have the important disorders in monocyte macrophage. Okay, important disorders of monocyte macrophage. For migration defects, this involves AIDS, diabetes, burns, immunosuppression therapy in newborns. Okay, impaired phagocytosis, this is seen in congenital deficiency of CD11 to CD18. Monocytic leukemia, systemic lupus erythematosus. We have also the Gaucher's disease. Okay, we have the Gaucher's disease. Okay, this involves a disturbance, okay, in cellular lipid metabolism. Okay, disturbance in a cellular lipid metabolism. This is a rare genetic defect of macrophage, okay, involving a deficiency of beta-glucocerebrosidase. Okay, beta-glucocerebrosidase. This enzyme, okay, normally splits the glucose from its parent sphingolipid, okay, okay, glucosyl ceramide, okay, its parent sphingolipid and glucosyl ceramide. Okay, as a result of the enzyme deficiency, what happens? There is accumulation of cerebroside in the macrophage. Okay, there is a what? There is an abnormal, okay, accumulation of cerebroside, okay, because, or this is due to the deficiency of the enzyme beta-glucocerebrosidase. Okay? So, we have the Gaucher cells. These are rarely seen in circulating blood, okay, but are found in the bone marrow, spleen, and other organs in the mononuclear phagocyte system. Okay, so what is presented in a Gaucher cell? The cell typically presents a large cell, okay, with 1 to 3 eccentric nuclei and characteristically wrinkled cytoplasm. Okay, wrinkled cytoplasm. We have the Niemann-Pick disease. Okay, Niemann-Pick disease, quite similar to Gaucher's disease as an inherited abnormality of lipid metabolism. So it is characterized by massive accumulation of sphingomyelin due to the deficiency of the enzyme sphingomyelinase. So we have the Pick cells, okay, which is similar to Gaucher cells but with a foamy, okay, with a foamy cytoplasm. Let's go back. What is the last option? The systemic inflammatory response syndrome. So this includes the progression of sepsis to severe sepsis and septic shock. So remember, sepsis begins when the innate immunity or the innate immune system responds aggressively to the presence of bacteria. Okay, so remember, itong systemic inflammatory response syndrome, combination siya ng severe sepsis and septic shock. Okay, that is caused, okay, by the presence of a bacteria, no? So, toll-like receptors cause the antigen-presenting cell to produce pro-inflammatory cytokines in the systemic inflammatory response syndrome. So, instead of this is not a congenital neutrophil condition, but rather an acquired condition. So among these choices, okay, it falls particularly with the Chidiac-Higashi syndrome. Okay, remember Chidiac-Higashi syndrome, okay, a qualitative congenital disorder of neutrophil. Okay, so the answer po in 46 is letter A, Chidiac-Higashi syndrome. Number 47. Number 47, HLA-B8 antigen has been associated with which of the following pairs of diseases? Letter A, we have ankylosing spondylitis and myasthenia gravis. Letter B, we have celiac disease and ankylosing spondylitis. We have letter C, myasthenia gravis and celiac disease. Letter D, Reiter disease and multiple sclerosis. Okay. So, which of the following pairs of disease are associated with HLA, HLA-B8? So, let's discuss first the HLA antigens. So, HLA antigens, these are products of the human major histocompatibility complex or MHC. This is also called as your human leukocyte antigen system. Okay, so this antigens, okay, these are cell surface proteins that bind to the antigen-specific T cell receptor, okay, forming an important signaling event, for cell-inducing or cell-suppressing of the immune response. So remember that HLA antigen's primary function is to serve as a recognition molecule in the initiation of an immune response. So the immune response of this, the initiation of immune response of the HLA antigens, okay, they present peptides from the foreign substances such as viruses and bacteria to the effector cells of the immune system. Okay, to the effector cells of the immune system. So the observation that some diseases are distinctly more common in individuals with a particular, okay, HLA allele or haplotype. Okay, this would allow studies on HLA and disease associations. So we have outlined here, this is from Turgeon, okay, table 31-4 ni Turgeon po. Okay, they have summarized the HLA antigen and the related diseases. So, mamaya tignan natin ha kung ano po yung mga HLA antigens related to our options, okay, in our choices. So, let's discuss first the disease association of HLA antigen. So, there are two general explanation for HLA and disease association. First, number one, there may be linkage of this equilibrium between the alleles at a particular disease association locus and the HLA allele associated with that disease. Okay, so this is true on the HLA antigen, HLA-A3, and idiopathic hemochromatosis. Another possible explanation to disease association of HLA antigen is that the HLA antigen itself, okay, they play a role on the disease. First, being a poor presenter, okay, being a poor presenter of viral or bacterial antigen. Or these antigens may provide a binding site on the surface of the cell for a disease-provoking viruses or bacterial antigen. Next, okay, HLA antigens may allow entry of a particular pathogen to the cell. And lastly, okay, resembling the pathogenic molecule, okay, so that the immune system will fail to recognize it as foreign, or it fails to mount an immune response against it. Okay, so in this question, okay, we want to identify which of the following conditions are related to HLA-B8. Okay, so we have ankylosing spondylitis. Ankylosing spondylitis is actually related to the presence of the HLA-B27. Okay, while your myasthenia gravis, okay, it is related to the HLA-B8. Okay, celiac disease. Okay, celiac disease, this is related to HLA-B8. Okay, HLA-B8. And then si ankylosing spondylitis, again, this is from HLA, it is associated with HLA-B27. Okay? Sige. HLA-B8 for both myasthenia gravis and celiac disease. So letter C is actually the correct answer. Reiter disease, okay, Reiter's disease or syndrome, this is associated with HLA-B27. Multiple sclerosis, on the other hand, this is actually 4 times risk of the presence of DR2, okay, would have a multiple sclerosis. So this is HLA-DR2. So importante na medyo familiar po tayo dun sa mga disease association. Okay, so this table is very, very helpful. Okay, so we have celiac disease and myasthenia gravis here, and other choices are here. Okay, so number 47, the answer po is letter C, myasthenia gravis and celiac disease. Okay, we have item number 48. Okay, item number 48, this is number 14, which laboratory assay is highly specific indicator and the most sensitive assay for diagnosing of rheumatoid arthritis. Okay, the choices, we have letter A, we have your cyclic citrulinated peptide. We have letter B, sensitized sheep cells. We have letter C, latex particle agglutination. Letter D, we have C-reactive protein agglutination. Okay, so let's discuss first rheumatoid arthritis. Rheumatoid arthritis, this is a long-term condition that causes pain, swelling, and stiffness in the joints. So, usually the patients with rheumatoid arthritis present symmetric and erosive arthritis, okay, with also involving multiple organs such as the heart and the lungs. So, it appears to be an association, okay, of the rheumatoid arthritis with certain MHC class 2 genes, encoding for the DR4, okay, DR4 HLA antigen. Okay, so clinical signs of rheumatoid arthritis involves swelling of the soft tissue around the 3 or more joints, swelling of the proximal interphalangeal, metacarpophalangeal or the wrist joints, okay, symmetric arthritis also, subcutaneous nodules, okay, a positive test also for the rheumatoid factor or RF, and radiographic evidence of erosions in the joints of the hands, wrist, or both. So RF or rheumatoid factor, these are group of immunoglobulins, IgG or IgM, but most typically of IgM in type, okay, that interacts specifically with the Fc portion of an target molecule. Target molecule is IgG molecule. So this is detected, okay, by testing synovial fluid. Okay, the synovial fluid macroscopically appears to be cloudy, okay, indicating a high amounts of protein and also a high WBC count of 5,000 to 20,000 cells per microliter. Okay, so what are the other presentation of the synovial fluid of a rheumatoid arthritis patient? Okay, it would present a negative test for the mucin clot test. Okay, so there would be a poor mucin clot development. Okay, and what else to be detected in that synovial fluid? Decreased complement, okay, and positive RF, or positive rheumatoid factor. So how do we test for rheumatoid factor? So we have this sheep cell agglutination test. Okay, sheep cell agglutination test. There would be agglutination if RF factor is present. Another test is anti-CCP, or cyclic citrullinated proteins. This is specifically associated with RA. This is a new biomarker for RA, okay, that is present as an autoantibodies against the cyclic citrullinated peptide, or anti-CCP. Okay, this is present in the serum of patients with rheumatoid arthritis and has been shown to be specific for RA, with approximately 95% specificity for the diagnosis of RA. So testing for both RF and anti-CCP may be beneficial when excluding the diagnosis of RA. Okay, so sheep cell agglutination test would identify RF factor. Okay, of course, the CCP testing, it would identify the autoantibody anti-CCP, okay, which is highly specific for RA. Okay? And then other tests involves latex fixation test, sensitized alligator erythrocyte test, bentonite flocculation test, nephelometric assay, okay, testing two other antibody classes of RF, which is your IgG or IgA. Okay, and also, these tests are correlated with the CRP levels and ESR, okay, which are both increased during inflammatory, okay, conditions. So treatment for this is the use of anti-inflammatory drugs such as salicylates and ibuprofen. Okay, disease-modifying anti-rheumatic drugs. We have your methotrexate, hydroxychloroquine, we have sulfasalazine, leflunomide, and penicillamine. Okay, and some corticosteroids, so steroids. Okay, so here, as we see, what is asked in the question is a laboratory assay that is highly specific for RA, or for rheumatoid arthritis, and this is the cyclic citrullinated peptide. Okay, the testing for the antibodies against cyclic citrullinated peptide. Okay, the answer is letter A. So, cyclic citrullinated peptide antibodies, okay, again, these are highly specific indicator for rheumatoid arthritis. Okay, so after the introduction of commercial ELISA products using the so-called second generation peptides, there has been increased interest in using this marker in the diagnosis. So anti-CCP antibodies, they are detectable, okay, in about 69 to 83% of patients with RA, and have specificities that can go beyond, or that can go up to 95% specificity. Okay, this is comparable, okay, from the other laboratory test for rheumatoid arthritis, and anti-CCP would give a high specificity, okay, for diagnosis. Okay, so we have other tests. We have sensitized sheep cells. Okay, so this is used in agglutination test for RF. So agglutination test for RF using a sensitized sheep cell, okay, test generally to detect the IgM rheumatoid factors. So IgM rheumatoid factors, this is manifested, okay, approximately, okay, 70 to 75% of adults, okay, but is not specific with or for rheumatoid arthritis. So some adults, okay, would present 70 to 75% of rheumatoid factor, okay, but not presenting symptoms of rheumatoid arthritis. So it is not specific for rheumatoid arthritis. Okay, so RF has been associated with some bacterial and viral infection. Okay, and some chronic infections such as cancer. Okay, elevated values may be observed, remember, in the normal adult population. So this 70 to 75% of adults can be not um, presenting signs and symptoms of rheumatoid arthritis, although they have rheumatoid factor in their blood. Agglutination test, letter C. Okay, letter C, agglutination test for using latex agglutination, okay, generally detect IgM-RFs. Okay, although a latex agglutination procedure has 95% correlation with clinical diagnosis, okay, probable or definite for rheumatoid arthritis, remember that rheumatoid factor is not exclusively limited to patients with rheumatoid arthritis. So remember, since ginagamit niya or hinahanap natin for using latex particle agglutination is IgM-RFs, which is not specific to rheumatoid arthritis exclusively. Okay, so this is not reliable, not as good as the anti-cyclic citrullinated assay or peptide assay. Okay, so we have the C-reactive protein agglutination test. So remember, CRP is a rapidly sensitized acute phase reactant. Okay, so acute phase reactant. So remember, okay, that acute phase reactant, okay, the CRP, okay, is an indicator of acute inflammation. So traditionally, CRP has been used clinically for monitoring infection, autoimmune disorder, and more recently, healing after, and more recently, we use this also CRP in myocardial infarction. Okay, the CRP rapid latex agglutination test is based on the reaction between the serum containing CRP as the antigen and the corresponding anti-human CRP, which is coated on the surface of the latex particle. Okay, so again, clinical application of CRP are used for the evaluation of inflammation, particularly infections, okay, and pwede rin po sa ating mga autoimmune disease, okay, and malignancies or cancers, okay, and monitoring of therapy in inflammatory diseases. For number 48 po, the answer is cyclic citrullinated peptide. Okay? Number 49. In an autoimmune disorder, conditions influencing the development of a disorder include the following factors with the exception of letter A, genetic factors, B, exogenous factors, C, immunopathogenic mechanism, or letter D, increased discrimination of self from non-self. Okay. So, let's discuss first autoimmune disorders. So, let's discuss first autoimmune disorders. So, autoimmune disorders, these are conditions in which there are damage to organs or tissues resulting from the presence of antibody, autoantibody, and autoreactive cells. Auto means self. Okay, so these are antibodies which are responsible in attacking their own antigen, and also T cells or autoreactive cells reacting to their own antigens. Okay, so autoimmune disease would present a loss of self-tolerance. Okay, so it cannot discriminate, okay, self from non-self. Okay, so hindi mo nakikilala na sa'yo pala yung antibody na yon, or sa'yo pala or sa'yo galing yung antigen na yon. Okay, so we have different mechanisms, okay, that will describe or explain the loss of self-tolerance in autoimmune diseases, and these are the following. We have number 1, formation of autoantigen autoantibody complexes. Okay, so sensitization of T cells which are dysfunctional. Okay, and also the genetic factors, so presence of certain HLA types, okay, are correlated with specific diseases. So these genes may be related with the production of this HLA, okay, disease-associated antigens. Okay, also mutation of immunocompetent cells, okay, causing alterations to antigens. And lastly, okay, there are foreign antigens or exogenous factors, okay, which react with self-antigen. So the following choices, okay, genetic factor, exogenous factors, and immunopathogenic mechanism, okay, clearly describes autoimmune disorders. So in this case, okay, sabi natin kanina, loss of self-tolerance. Hindi niya makilala yung sarili niya. Okay, so this is not described by letter D. Okay, increased discrimination of self from non-self antigen. Okay, in autoimmune disorder, we cannot, okay, there is no discrimination of self from non-self antigen. Okay, and that produce a certain, okay, immune response, okay, to the patient. So again, okay, the autoimmune disorders, okay, there is a decreased rather than increased discrimination of self from non-self antigen. Okay? So, dagdag lang natin ha. So, genetic risk factors, okay, for the development of autoimmune disorders. So, any genetic change that reduce deletion, okay, or enhancement of activation of autoreactivity may be a risk factor for the development of autoimmune disorders. Okay, so the association of genetics and autoimmune disorders focus on the common allelic variants, okay, but not on clearly, okay, not on just mutations. Okay, what else? We have exogenous factors. So exogenous factors may also include not just the foreign antigens, which are your viral antigen or bacterial antigen. Okay, pwede rin po itong UV or ultraviolet radiation. Meron din pong drugs. Okay, and other chronic infections that may cause or play a role in the development of autoimmunity. Okay, so remember that these factors, okay, may alter the antigen, okay, which the body can perceive as non-self antigens. Okay, immunopathogenic mechanism. Okay, immunopathogenic mechanism naman po. Okay, so the autoimmune disorders are usually prevented by normal functioning of immunologic regulatory mechanism. So if this mechanism is affected or is malfunctioning, so antibodies to antigens, to self-antigens may be produced and bind to antigens to the circulation. Kapag ito po ay nasa circulation natin, itong immune complexes na ito, okay, these antigens will be deposited in specific tissue sites. Once there is deposition of this, okay, immune complexes, okay, what will happen? This antigen-antibody complex will accumulate in this tissue. The complement will be activated. Okay, complement will be activated. Okay, with the subsequent release of mediators, okay, that will enable inflammation. Okay, that will enable inflammation. That is described in letter C. Okay, so number 49 po, again, the answer is letter D. Increased discrimination of self from non-self antigen is not, okay, a description of autoimmune disorder. Okay, dapat daw po decreased ito. Okay, so number 50, which autoimmune disorders is characterized by this ANA pattern? Okay, ANA pattern shown in this image. Okay, in an immunofluorescence microscopy test for anti-nuclear antibodies. So we have the following choices: A. Sjogren's syndrome, B. CREST syndrome, C. Systemic lupus erythematosus, or letter D. Scleroderma. Okay? So, this procedure, the FANA testing, this is the fluorescent anti-nuclear antibody testing. Okay? So, we use immunofluorescence. Okay? So, that is now termed as fluorescent anti-nuclear antibody test. Okay, so the principle of this test, we use indirect fluorescent antibody procedure, okay, for the detection and semi-quantitation of human anti-nuclear antibodies. Okay, so we use human epithelial cell, okay, that is the HEP2 cells, okay, that is being used, okay, in this test. So observation of specific pattern of fluorescence on HEP2 cells indicate the presence of autoantibody in a patient's serum. So from our, please use the handouts. Meron po tayo doong tables, okay, which describe the specific patterns of ANA. Okay, from that table, we know that this is the homogeneous, or we term as solid or diffuse pattern of ANA. Okay, so this pattern suggests the presence of anti-nuclear DNA. Okay, we have the anti-dsDNA, anti-single-stranded DNA, and anti-DNP, or the deoxyribonucleoprotein, and some antibodies to histones. Okay, so in homogeneous pattern, okay, it highly suggests the presence of anti-dsDNA. Okay, anti-dsDNA. Although marami pa siyang other nuclear DNA, but this suggests, okay, commonly among anti-dsDNA antibodies. So this is most specific or most highly correlated with SLE, systemic lupus erythematosus. Okay? So, it suggests diagnosis if this is found as a pattern in ANA staining, okay, and also determine that the present autoantibodies is anti-dsDNA, alongside with the combination with low levels, okay, with low levels of complement. Okay? So, mababa ang complement, okay, concentration sa ating serum. Okay? Particularly C3 molecules. Okay? So, it gives a sensitive assay if we test for anti-dsDNA using immunofluorescent test using Crithidia lucilei. Okay, remember that. Okay, a homoflagellate was used as a substrate to detect the presence of anti-dsDNA. Okay, so here, in our choices, it would suggest, okay, highly suggest systemic lupus erythematosus. Okay, systemic erythematosus. Okay, Sjogren's syndrome can also be seen here. Okay, but in a much larger population, okay, it is more encountered among SLE patient, accounting to the high presence of anti-dsDNA. Okay, pwede rin po, sabi kay John, pwede rin po ang peripheral, pwede rin po ang speckled, pwede rin po ang nucleolar, KK, Sjogren's syndrome. CREST syndrome, this is highly associated with the discrete or the centromere ANA pattern. Okay, scleroderma. Okay, scleroderma can be also described in a nuclear pattern, okay, in a nucleolar pattern in ANA staining. Okay, suggests nucleolar pattern in ANA staining. Okay, so very important po na alam po natin sila, ha. So, lalo na po kay SLE, lahat po ng possible staining patterns kay SLE, please be familiar with. So, we can be associated with the speckled pattern. Okay, pwede rin po kay homogeneous pattern. Okay, speckled pattern po, the autoantibody present, okay, or detected is the anti-SM or the anti-Smith, okay, antibody. Okay, so that is specific also for lupus, okay, conditions. Okay. Number 51. Iana is a 30-year-old female who felt tired for several months. She had pain in the joints of her fingers and recently developed a dermatitis following exposure to the sun. Okay? Um, The following test results were obtained on her blood sample drawn during the initial evaluation. We have the following laboratory tests. We have the total protein of 8.4 gram per deciliter. Okay? Medyo mas mataas. Okay, ng 0.4 gram per deciliter. ANA of more than 1 is to 2,560. Okay, showing speckled pattern. CRP positive, okay, and then C3 is 40 milligram per deciliter. Okay, mababa ang ating C3, okay, of a below level sa ating normal value of 80 to 180 milligram per deciliter. C4, mababa din po. We have 5 milligram per deciliter, okay, C4. So, what could this be suggesting? Okay, so again, sabi natin kanina, okay, SLE can be observed also among ANA pattern, which is a speckled pattern. Okay, and remember the presence of autoantibodies, okay, in those patterns alongside with the presence of decreased complement would highly suggest okay, systemic lupus erythematosus. Okay, so bukod doon, okay, bukod sa laboratory test natin, okay, there are also presence of joint pain and dermatitis. Okay, joint pain and dermatitis. Okay, in a woman of a childbearing age. So this supports okay, presence or a condition which is a systemic lupus erythematosus. Okay, the answer po is letter B. Okay, so to add also, anti-nuclear antibodies okay, are found among 95% of patients with SLE, and a speckled pattern, okay, a speckled pattern is commonly found in patients with SLE. Okay, so this would indicate presence of antibody to a variety of non-histone small RNP particles or the ribonucleoprotein particles. Okay? So, when naman po, ma'am yung rheumatoid arthritis po, pwede rin po siya ma-associate with speckled pattern. Tama ba? Yes po. Okay, tama naman siya. Okay, so speckled pattern can be associated with systemic autoimmune rheumatic diseases other than SLE. So this can be rheumatoid arthritis, pwedeng RA, pwede rin pong Sjogren. Okay? Pwede din pong scleroderma. Okay? And pwede rin pong SLE, di ba? So, ito nga yung kinonsider natin. Okay? So, the possibility of SLE is increased if the patient, okay, with that high titer, as in this case, is present, and also, okay, a CRP level, okay, is also detected. As high CRP level indicates inflammation, okay, which is occurring or observed among SLE condition. Okay? Although the high CRP levels, okay, does not actually pinpoints a specific location of inflammation, okay, it can suggest okay, presence of acute inflammation. And also, so speckled, tapos may CRP. Bukod doon, what we have observed is a decreased complement levels. Okay, so this is associated with autoimmune disease. So remember po sa ating kanina, okay, in SLE, okay, bukod kay homogeneous anti-dsDNA, okay, mababa rin po ang ating complement, particularly si C3, pakidagdag din po si C4. Okay? So C4 levels, okay, C3 and C4 levels are typically depressed in SLE condition. Okay? Kay rheumatoid arthritis, itong mga complement na to, they are usually normal or increased due to acute phase reactivity. Okay, so number 51 po, the answer is letter B. Okay, it would highly suggest systemic lupus erythematosus. Number 52. A patient had a differential diagnosis of SLE. All of the following specific laboratory tests meet the criteria for a definitive diagnosis of SLE except the laboratory test or result includes an ANA positive homogeneous pattern, titer of 1:320, an RA or rheumatoid arthritis positive, complement is decreased. Okay? So, the choices are A, positive anti-nuclear antibody, and B, Smith antibodies, C, double-stranded DNA antibodies is present, and ribonucleic or RNP antibodies is present. So, remember in SLE, okay, in SLE, RNP antibodies are not specific. Okay? Ribonucleic protein antibodies in this case is an exception. All of the following choices except letter D, okay, is associated with a definitive diagnosis of SLE. So, in this case po, hindi po sagot ang letter D, ha? So, RNP antibodies, these are not specific for SLE or systemic lupus erythematosus. Okay? So, a positive anti-nuclear antibody or ANA, so initial laboratory result demonstrating positive ANA or anti-nuclear antibody. Okay? So, in a screening for lupus erythematosus, okay, also includes also an RA, okay, an RA testing or the rheumatoid factor testing. Okay? So, this screening assays detects the presence of antibody which are linked with rheumatoid arthritis and other conditions such as systemic lupus erythematosus. Okay? And renal disease in patients with SLE is indicated by assessment of levels of complement levels such as for C3 and C4. So in this case, there was a decreased level of complement, okay, suggesting that the classic complement pathway may have been activated, resulting in immune complexes. So, clinically significant indication could be tissue damage, particularly renal diseases. So, patients with SLE are characterized by the presence of antibodies to multiple antigens, but some of these antibodies are not exclusive to SLE. Okay, so dahil mababa yung C3 and C4, okay, it can present renal disease. Okay, it can present renal disease due to tissue damage of these complexes. Okay, so we have also extractable nuclear antibody, which is your Smith antibody. Remember, your Smith antibody is highly specific for SLE. Okay, but this occurs only specific antibody siya for SLE, but only occurs for about 35% of cases. Okay. We have also double-stranded DNA antibodies. Double-stranded DNA antibodies or dsDNA antibodies. Okay, so a titer of more than 1:10, okay, detected by immunofluorescence assay is seen in up to 50 to 60% with patients of systemic lupus erythematosus. So this antibody indicate an active disease. Okay? So number 52 po, no, letter D is the answer. 53. Maria feels stiffness in her fingers. Okay? Has a positive anti-nuclear antibody test with a centromere pattern at 1:1280 titer. What is most likely the diagnosis? We have A, SLE, B, rheumatoid arthritis, C, Sjogren's syndrome, or D, CREST syndrome. Okay, kanina sinabi natin si centromere pattern. Okay, centromere pattern, okay, or a discrete pattern in ANA staining, okay, would suggest CREST syndrome. Okay, CREST syndrome. Number 53, the answer is letter D. So, centromere antibodies are present. Okay, centromere antibodies are present on half of patients of CREST syndrome. This is an acronym named after the major features of autoimmune disorders. We have the calcinosis. We have the Raynaud's phenomenon. We have the esophageal dysmotility. We have sclerodactyly and telangiectasia. Okay, so while the ANA result alone is not diagnostic in this patient having clinical symptoms of stiff fingers, okay, that fits nicely with the centromere ANA pattern. So, be specific tayo with the centromere antibodies, okay, only half of those patients, okay, with CREST syndrome would present, okay, a centromere pattern. Okay? So, systemic lupus erythematosus, ano ang usual pattern natin? Okay, it can be, if dsDNA is present, anti-dsDNA present, we have the homogeneous, okay, pattern. If anti-Smith, this is highly correlated with the speckled pattern. Okay, speckled pattern. Okay, so homogeneous or can be a speckled pattern for SLE. For rheumatoid arthritis and Sjogren, okay, usually of a speckled pattern. Both are usually speckled pattern. Okay, ito centromere or a discrete, okay, or discrete pattern. Number 54. All of the listed disorders are organ non-specific autoimmune diseases except letter A, systemic lupus erythematosus, B, systemic sclerosis, C, rheumatoid arthritis. So ito sure tayo na hindi siya organ specific autoimmune disorder. But from the word systemic, so meaning to say it is it is an organ non-specific autoimmune disorder. Okay, the Hashimoto disorder is actually the answer for number 54. Okay, so remember in our previous discussions, okay, Hashimoto disease, okay, this is also known as the lymphoid chronic thyroiditis. Okay, this is an endocrine disorder and a classic example of an organ-specific autoimmune disease. Okay, so in this example, the autoimmune process in which the development of circulating cytotoxic antibodies eventually destroy the thyroid gland. Okay, so the autoantibodies are directed against the thyroid gland. Okay, the thyroid gland. And this will later produce, okay, the condition of hypothyroidism. Okay, it will eventually cause hypothyroidism. So, organ-specific autoimmune disease are produced by T-cell or antibodies against antigen, okay, restricted to a single organ. So, in this case, meron tayong antibodies na pinoproduce against sa thyroid gland, causing, okay, hypothyroidism. Okay, hypothyroidism. We have your SLE. It is a classic example of a systemic autoimmune process by circulating antibodies or immune complexes that affects multiple organs. So, in this term, systemic, so it refers multiple system in the body. So, this is not, this is considered as a organ non-specific disease. Okay? What else? We have this systemic sclerosis. Okay, systemic sclerosis. Okay, this is a progressive systemic sclerosis or scleroderma. Okay, this is a collagen vascular disease. Okay, idiopathic scleroderma is considered as an autoimmune disease because of its association with the autoantibodies, okay, and overlapping syndromes of scleroderma, polymyositis, and scleroderma SLE. Okay? So, in this case po, systemic sclerosis from its term, systemic, okay? This is a an organ non-specific autoimmune disease. Rheumatoid arthritis. Okay, rheumatoid arthritis does not have a clear boundary with more than 100 different conditions being labeled as rheumatoid diseases. Okay, so RA is a chronic multi-system autoimmune disease disorder. Okay, it is a chronic multi-system disorder. So, hindi lang po joints ang inaapektuhan nito. Kanina sabi natin, it can also go beyond, affecting the heart, lungs, and other parts of the body. Okay? The current model of pathogenesis of RA, okay, proposes that an infective agent or stimulus, okay, binds the receptors of the dendritic cells, okay, that activates the innate immune system. Okay, so 54 po, Hashimoto disease is an organ-specific autoimmune disease.